All right, everybody, it is time to get started. Now, I'm just going to give a heads up for those joining on YouTube, Facebook, wherever. We have our set start times, and that's when we're going to get started. We start the stream early to make sure that tech is working, right? Because sometimes there's tech issues that pop up, and we want to make sure. Oh, sorry, hold on. Give me 1 second. There we go. We want to make sure that everything is running smoothly, which is why we started early. So we do need to be kind in the chats. If we are rude to chat support, if we are not kind, we'll just remove the comments and make it where you can't comment. So please don't do that. Let's just be nice to one another. We are offering these for free. We want to provide you value. We want to see you pass the NCLEX exam. That is why we are here. So let me know if audio is working in Zoom. I have one person letting me know that, hey, they can't hear me. So let me know if audio is working okay in Zoom. Give me that little heads up there if you can hear me. Okay, perfect. It is working. Amazing. Thank you, Rachel, for letting me know. Thank you for those letting me know that it is working. Perfect. So let's go ahead. Let's get started. I'm excited for the next 45-ish minutes. It might take us an hour. We'll see how long I talk, but we're going to go through a nursing case study today. And I think it is going to be a ton of fun because I want us to get used to these real life scenarios. I want you to get used to the 6 steps of clinical judgment and really understanding how we work through these client scenarios. Now, why is that important to me? It's important to me because when you go take your NCLEX exam, you're going to have 3 to 5 unfolding case studies. And the more that you can get comfortable with what these unfolding case studies look like, the better you're going to do on them. And the more you're going to be able to work through clinical judgment and critical thinking. Now, if you're joining today and you're like, hey, I know somebody else who's prepping for the NCLEX exam, or I know somebody else in nursing school, because this is applicable to both of you all, I want you to go ahead, tag them, share the live if you want. We want to see every nurse who wants to pass their NCLEX pass it. We want to help as many students as we possibly can. And this is a free resource. So tag them, share if you feel called to do so, and let's go ahead and let's get started. Now, I want to know where you all are joining from. We like to utilize something called slido.com. I'm not sure why our Slido code changed, but it's PCC. So join me. PCC is the Slido code. Go ahead, type that in. And when you do, we are going to get started. Texas, Michigan, California, amazing. We're going to utilize this a lot today, by the way. So go ahead and start now because it allows me to take people on TikTok, people on YouTube, people on Facebook, people on Zoom, and it puts all your responses in one spot so I can easily see them as the presenter. The United Kingdom, cool. That's really cool. Wichita Falls, Texas, Virginia, Calgary, Germany, Arizona, North Carolina, Australia, the Philippines. I'm pretty sure it's really late in the Philippines, right? Pretty late at night. Awesome. San Diego, Florida, amazing. Oregon, New Jersey. We have people from all over Canada, and not over just the country, the world. And I think it is so cool. Now, if you are joining on Zoom, the Q&A is going to be the best place for you to put your questions. So I'm actually going to make it where you can't put your responses in the chat. I'm just doing that so it's easier for our chat support if you put them in the Q&A in Zoom. Zoom's kind of weird. It has 2 spots. And it's easier for our chat if they're all in that Q&A where your questions are. But our chat support can send messages to you in the chat in Zoom. If you're joining on TikTok or Facebook or YouTube, just put it in the comments. That works great. Let's go ahead and get started. Amazing. People from all over. I think it's the coolest thing. So we're going to go through a case study example. So here's the case study. We're going to meet our client. We have a 65-year-old male patient admitted to the emergency department with a high-grade fever, altered mental status, and a blood pressure of 80/40. Okay, we've got some red flags going on. When you notice a red flag when I'm going through this, I want you to drop it in the chats. Let me know what red flags you're seeing. His initial lab results show an elevated white blood cell count and lactic acidosis. what would be your initial assessment and nursing interventions? Ooh, all right, let's think for a moment. I'm going to put a Slido slide up in just a moment so that you can think through this. But there's some red flags here. There are some concerns that I see. So what are you guys noticing? Let me know in Slido. Based off that initial assessment, what are we thinking? What are we worried about here? What interventions might we want to do right now? That blood pressure is pretty low. They also had that elevated white count, right? They're hypotensive. They had a high grade fever. What about the white count? Do we care about the white count, the lactic acidosis? Is that important? Does that matter? Yeah, those are some concerns, right? So right off the bat, you're probably already having some thoughts go through your head of like, ooh, what's going on with my client? You should automatically be thinking of several different things that it could be right now. So let's look at this one more time. And I want you to think, what do you think our client has? And drop it in the comments. If you were to have all of these client findings, that's what we first did, is called recognizing cues. That's the first step to clinical judgment. Then we're going to move on to the second step of clinical judgment, and that's analyzing those cues. It's putting all of them together and giving them meaning. So if I were to give this client meaning, what do I see? That my client might be in septic shock. You guys got it. This client is likely in septic shock. My initial assessment, well, what do I want to look at? I need to see what vital signs are doing. I'm going to be watching that blood pressure pretty closely because when my MAP gets too low, my vital organs are no longer transfusing. And we want a MAP of what? Does anyone know what we like our MAP to stay at or above? This is coming from an ICU nurse. Anyone know? So I'm seeing some different numbers here. Some are saying 60, some are saying 70. We really like 65 and above. Sometimes, depending on the doc and the client, we would say 60, but usually 65 and above is what I'm looking for in the ICU. And that tells me with MAP that at least the vital organs are getting oxygen, they're being transfused. If we have a decrease of 65 in MAP, I'm concerned about those vital organs. And are they getting blood flow? Are they then getting oxygen? Now, when somebody is in sepsis or potentially septic, there's a specific thing I want to do right now. What would you guys want to get from this client? What would you want to get from this client? What would you want to check to confirm, is this sepsis or is this not sepsis? How would we confirm it? What would we check? Someone said check an ABG. I like that, but not what I'm looking for here. Yes, blood cultures. We would check blood cultures. We might check an ABG because it's going to be abnormal, right? But I really want to check blood cultures. And when we do blood cultures, and we're going to talk about this again, we don't just check them from one site. So we'll talk about that in just a moment. Now, after we take those blood cultures, that's when we can start those broad spectrum antibiotics. So what other assessment findings would you see in septic shock? What other assessment findings would we see? Let me know. What are we thinking about? Tachycardia. Nice. Whoever put that, you are absolutely right. We actually will sometimes see the tachycardia before we see the drop in the blood pressure. It sometimes happens first due to the stages of sepsis. The Slido code today is PCC. High white count, low blood pressure, elevated BUN and creat. Nice. Whoever put that, great job. What do we think urine output might do? No one's talked about urine output, but when someone's in sepsis, what do we think their urine output is going to do? Let's see, has anyone said it? Decreased UOP. Nice. We're going to see a decrease typically in that urine output. Nice. Olyuria, you got it. So let's keep going through our case study here. Awesome, awesome start. Early recognition is so important in septic shock. So we have to think about what other interventions we would need to prioritize. So when I'm thinking about prioritizing, I'm going to assess the client's oxygen saturation. They might need to be on supplemental oxygen. And then we want to initiate intravenous fluids. And we're going to utilize two different fluid types. That includes crystalloids and colloids. So here is my little tip. Crystalloid fluids are going to be clear. When I hold them up, they are crystal clear and I can see through them. With colloids like albumin, we can't see through them, but we give colloids. And does anyone know what colloids are going to do for my client? What are they also called? If I were to be using them in the ICU, I may have a different name than colloids. Anyone know what else we call it? Any guesses here? So we would also call them plasma volume expanders. These can be volume expanders, right? Where I need more volume in the vessels. So when I give albumin, what does it do? Well, albumin is like the life of the party. It's a protein. We have to have albumin in our vessels because it's going to attract all of the fluid and it's going to keep the fluid in the vessel. So if I don't have albumin, I cannot keep fluid in my vessels. But then when we give albumin, it's going to stay in the vessels. Now, Jeffrey, amazing job. You got that correct on Facebook. It looks like you're joining from. So nice job getting that one. So albumin, life of the party. How I think of albumin is like every little albumin particle is like a baby sponge, and the fluid wants to be where that sponge is at. It's the life of the party. Now, packed red blood cells, fresh frozen plasma, both of those are also going to be volume expanders as well. Now, how much urine output per hour tells us good kidney status? Tells me that, hey, my client's doing okay. Organs are working okay. What do I want to look for here with urine output? Megan, kudos to you. Megan joined on TikTok to let us know that they passed their NCLEX utilizing Archer Review. Congrats. We're so glad we could be a part of your journey. If I missed anyone else passing, I'm sorry. Kudos to you also. Just happened to see that one. So a lot of you are saying 30 mils per hour, but somebody said 0.5 mils per hour. That's almost what we're looking for. It's not quite there. It's 0.5 mils per kilogram per hour to get really specific. And someone put it in there. Yep, 0.5 mils per kilogram per hour or 30 mils per hour is accurate. So on average, typically when you're tested, we're going to say, hey, 30 mils per hour is what we're looking for. But I want you to think of something like in the ICU, if I have a 90-year-old, 80-pound woman and I have a 350-pound man, do we think their urine output might look slightly different between those two individuals? What do we think? Do we think urine output might vary between them? Absolutely. So that's why when I'm in the ICU working, or if we were on a burns unit working, we're going to probably get more specific with urine output. Now, on average, I like to see the 30 mils per hour. When I'm not seeing 30 mils per hour, that's when I start to get a little bit concerned. Are my organs working? Are my kidneys transfusing? Now, I want you to think for a moment, when the kidneys aren't transfusing, what ABG imbalance might we see? I know I'm totally going off script here, but I want to take this one step further. What ABG imbalance would I see? Someone said acidosis. What type of acidosis? Nice. Nice. Y'all are awesome. Great job. It's going to be metabolic acidosis. So let's think about this for a moment with metabolic acidosis. Why are we going to see a metabolic acidosis? Well, if my kidneys aren't transfusing, what happens? They can't make what? Bicarbonate. Bicarb is a base. And if we're not making base, our client is going to go into a metabolic acidosis. Amazing job. And it's because those kidneys aren't getting enough blood and therefore they're not getting enough oxygen. Incredible. Now, next gen NCLEX. I want to talk about this for a moment. Even if you're in nursing school, you want to understand this because you're prepping for this throughout nursing school. So I wanted to discuss next gen NCLEX because really what next gen NCLEX is going to think about is your ability to critically think, your ability to pull from the 6 steps of clinical judgment and clinical judgment itself, your ability to make decisions on the fly. Is there something changing with our client? They looked like this at 0800, it's 0845, and this change has happened. What are we going to do? And so we're really working on that clinical reasoning. And it's going to cover a wide range of topics like septic shock. That's just one of them. You're going to see multiple choice questions. You're going to see case studies. You're going to see those next gen style questions. They could be bow tie questions. They could be highlight the table questions. So I really want to make sure that you guys understand what next gen looks like. So you'll see anywhere from 3 to 5 unfolding case studies. 2 of those, if you get 5, are not scored. If you get 4, 1 of those are not scored. The reason why is they'd be part of those pre-test questions, but you don't know where the pre-test is occurring. And my name's Rachel Taylor, by the way. I saw somebody asked, Rachel Taylor. So anyway, with this, okay, what happens is they're testing you on those unfolding case studies, and those questions are going to be static. They're not adapting to you. But then about 10% of your test, your standalone questions, can be next gen questions. And like I said, those are your bow ties, your highlight the tables. You might have some like drag and drops, different boxes. You could have rationale scoring questions where it's like a fill in the blank of a sentence. And so you want to make sure that you practice these question types. And so at Archer Review, what we have is our SurePass combo. This is my top recommended combo. If you are new to Archer Review, if you have no idea what Archer Review is, this is the package if you are prepping for your NCLEX exam that I would want you to get. There's one for RN, there's one for PN. So our SurePass package, what does it include? It includes, I don't even know how many unfolding case studies off the top of my head, a lot of them. I think total we have like 800 next gen NCLEX style questions between our unfolding case studies and our standalone item types. And then it's going to include our on-demand videos. There's over 100 hours of on-demand videos. And then our Q-Bank. Our Q-Bank for the RN has over 2,900 practice questions. And it's totally different from our nursing school practice questions. So if you also are getting nursing school and you're like, oh, is there going to be a ton of overlap? There won't be because the questions are totally different. And it includes our 3-day live review. Our next 3-day live review, and you get to pick which one you attend within the time frame of your package, is October 2nd, 3rd, and 4th. And it's a 24-hour high-yield NCLEX review with an awesome workbook that comes along with it. So if you're brand new here and you're like, ooh, I don't know which package I should get, SurePass would be the one. We have a question writing team. And this question writing team has gone through all the classes on writing NCLEX style questions. And somebody asked, hey, are these similar to yes, they are written by nurses who have the appropriate training to write NCLEX style questions for our NCLEX Q-Bank. So someone said, hey, how similar to NCLEX are these? Don't take my word for it. Go check out our Facebook page. Go check out our testimonials that are listed on our website. Students are giving reviews every day of how they think our Q-Bank is and how it lines up. And majority of them say it's very similar to the NCLEX. Now, it's not going to use the exact same wording. You're not going to see the exact same question, but it should prepare you on how to think through questions, how to know how to use testing strategy, how to get them right, even when you're not fully sure. That's the testing skill I want you to gain from answering 2,900 practice questions, right? Amazing. Someone, E on TikTok, said they passed the NCLEX 2 days ago and said the Q-Bank mimics the NCLEX to a T. Good luck. E, thank you for that feedback. That's awesome. Thanks for letting us know. We've got another one. Dungeon Dragon is the name on TikTok. Passed NCLEX on first attempt, and it was similar as well, they said. Amazing. Amazing, amazing. Now let's talk through our nursing interventions. We left our client alone too long, right? Let's get back to our client. We don't want to leave them when they're in sepsis. So let's go back to our case study. What other interventions do we want to consider here? Well, we need to make sure that we're watching our client's response to the interventions and we're constantly reassessing. As nurses, we just want to reassess, reassess, reassess. So what we're going to do is we're going to start with broad spectrum antibiotics after we had already drawn, right, those blood cultures. We got 2 sets of blood cultures, then we're starting on a broad spectrum antibiotic. Once we get the results of those blood cultures, that's when we can actually go ahead and go more specific. Now, we also are going to consider fluids because we might give vasopressors, but we have to fill the tank first. So when I think of giving fluids is going to fill the tank so that the vasopressor can squeeze the tank. It can squeeze the vessels to help increase pressure. Now, why do I not keep giving fluid bolus after fluid bolus after fluid bolus? What do we think? Why do we do a whole bunch of fluid boluses? Why do we do 2 and then we don't keep going? That's how I should have worded that. We don't want to cause fluid overload, right? We want to make sure we don't cause any fluid overload. Nice. You guys are getting it. But we're going to give a couple because we want to bring up that blood pressure. And that's when we're then going to start the vasopressor. With the vasopressor, we titrate it, meaning we adjust the dosage to keep the MAP typically above 65. So how would you want to monitor? What things would you want to monitor? Let me know in the Q&A, in the chats, how would you monitor this client? Nice. Strict I&O. Yeah, absolutely. Nice. You got it. What else might we consider? How's the client responding? If their blood pressure comes up, well, then we're not going to be on vasopressors anymore, right? If their MAP is good, if all those things are good, then we're okay. Now, the other thing we need to assess for is end organ damage. So with end organ damage, what would we look for? How would we know if our organs are suffering? What things are we going to look at? I know there's a couple things on the screen. Checking BUN creat, checking the color of urine. Yeah, if urine starts to dramatically decrease, guess what? Our kidneys are probably starting to have end organ damage. If our brain is not working appropriately, their level of consciousness is changing. Now our brain is probably not perfusing well enough. If we start to see respiratory issues, then our lungs are not perfusing well enough. This can affect every organ of the body. We can see dysfunction everywhere as those organs don't get enough oxygenation. So what are we going to prioritize? We've been talking about this, but there's a specific treatment that we use in the hospital when someone's in sepsis. Anyone know what that is? What are we prioritizing right now? What are we prioritizing? Nice. You guys are saying it. All the things that you are saying is sepsis treatment timeline. So what we're going to do first is we're going to get those blood cultures. We said 2 sets because we don't want the one to be contaminated. And then we are going to make sure that we have started an IV. Now, do I want just one 20 gauge, 24 gauge IV? Or do you think we are going to need more? Do you think we're going to need more than one IV? And what size of IV do you think we would really want in this scenario? You guys are saying 18 gauge. I would love an 18 gauge in this client. And really the reason why is there's a good chance that I'm going to be giving some pretty intense meds. Like vasopressors are tough on those vessels. I want to make sure I have a good enough IV placed. Nice. And we're going to want a couple. I don't just want one IV. Preferably what I like in the ICU is a central line, right? If I can get a central line placed on this client, we're going to have a lot easier of a time giving all the meds, giving all the things that I might need to give. And someone said, yeah, we might have to go with a 20 gauge if those veins aren't quite as big. If we're struggling to get a vein, they might go with a 20. Absolutely. Now, the other thing that we need to do within 60 minutes of them flagging, hey, I think they have sepsis, we need to start vancomycin. We have 60 minutes to get that started from the time of the recognition of sepsis. Vancomycin should be given over an hour. Does anyone know why we give vanc over an hour? Why don't we give it quicker than that? Nice. Eliza May, Yasoda, you got it. Red man syndrome. Red man syndrome is a big risk with vancomycin, and it typically happens if vancomycin has been transfused too quickly. Now, as soon as we see, hey, low blood pressures are starting, MAP is trending down, then we need to start our fluid boluses. Typically, we're going to start with 2 liters of a fluid bolus that is an isotonic fluid. A lot of times, normal saline is what we're going to be utilizing. After 2 boluses, if they're not responsive, if the blood pressure is still low, that's when we're giving a vasopressor. Now, earlier someone asked, what are some examples of vasopressors? And here they are. Epinephrine, norepinephrine, vasopressin, dopamine. All of these are going to work to squeeze those vessels to increase blood pressure and overall improve perfusion. So what are our cares that we need to be doing? Well, once the client is stable, we're going to think of just general care, right? So I want you in the Q&As, in the chats, to let me know what care would you want to provide to your client once they're stable. We might start some internal feedings. What else might we do? And that's if they couldn't take anything else by mouth. But I want us to think big picture. So before, we prioritized the hypothesis, which means we prioritized our key finding of sepsis. But once we do that, we then have to think bigger picture. So what other things might we do? Now, someone said an indwelling urinary catheter, and I'm going to say that depends. You know, I want accurate INOs, so we probably are going to place one, but what risk does placing that catheter come with? Why would I be concerned or cautious about catheter placement in this client? A CAUTI. So it really will depend on the situation. It will depend how alert the client is. It will depend if we can, you know, have them get to the bathroom safely, accurately measure their urine. If not, which there's a good chance we might not be able to, we will consider the use of a catheter. But we need to be cautious. And if we do end up using that catheter, as soon as the client doesn't need it, we need to remove that catheter because we don't want to use it when we don't need it. Now, here's what can happen when someone doesn't eat for a long time. They end up having this hemodynamic instability because they haven't consumed good enough food, and now their body is a little bit like, whoo, what's going on? So we're going to have to watch their volume levels. We do that by INOs, daily weights, right? Daily weights are a great way to say, what is fluid status doing every day? We're going to watch their blood sugar, right? If somebody hasn't been consuming food, that's going to throw their blood sugar off. But then if we start them on TPN or we start them on internal feedings, maybe their body doesn't respond quite right. And we want to see what their blood sugar is doing. We also need to watch really closely for electrolyte imbalances. A lot of times when someone is septic, we can see that their sodium gets thrown off. We can see their potassium gets thrown off. So we want to watch those closely. Now, if you're interested in going through sessions similar to this in a small group setting, right now, I think I've got like 500 of you listening in across all of our platforms. If you want to go through this where it's a smaller setting, up to 20 students, that's what small group tutoring is for. $25 per hour session. We have sessions that we don't offer for free, like our 2-hour NCLEX review. That's something that Kate and Lauren actually have, I think, tomorrow. I have one coming up in several weeks. We've got mock NCLEXs. Trying to think, farm memory tricks. That's one of the most popular small groups we have with Kate. Awesome things, and you do get a discount the more you book. So if you're interested, check out that small group tutoring. If that QR code isn't working for you, you can just go to Archer Review Tutors and check out the small group tutoring there. I will go ahead and show you how to book those at the very end of the session. For anyone who's interested, you can stay on. But let's move on and kind of move forward. Do you guys want to do one more case study example? What are we thinking? Do you guys want to do one more case study, or do you want to wrap up? Okay, I'm seeing yeses, like, hey, let's go ahead. Let's do one more. Okay, I've got one more for us. Let's do it. Let's do it. So here's our client. We've got an 85-year-old female admitted to the ED. She's febrile and appears confused. She has a history of GERD, macular degeneration, urinary incontinence, and the initial results show leukocytosis and elevated lactate levels. Ooh, okay. What are we thinking? What are we thinking here? Leukocytosis. That's a tough word. That's a big, kind of tough word. What does that mean? Anyone know what leukocytosis means? Someone is saying UTI. Lots of you are saying UTI. Was there anything that gave it away? What was one of her early symptoms? What was her confusion, right? When I see confusion in the elderly, one of my first thoughts is like, oh, do they have a UTI, right? Because I see it all the time. We in the ICU would sometimes get clients from nursing homes. They'd be direct admits from their nursing home, and they would go from being completely alert and oriented to when they got to me, they didn't know who they were, where they were. And most often it was one of two things. They either had a UTI or their sodium level was really off. And in those two cases, which I saw often in the elderly, we would see this massive confusion. Now, the other big kind of takeaway or giveaway, I should say, is that this individual has urinary incontinence. Does urinary incontinence increase the risk of potentially having a UTI? If they're incontinent, maybe they have some retention going on. Are we going to see? Yeah. And Queen on TikTok said the leukocytosis is a high white count. You got it. Absolutely. So when you see those big words like leukocytosis, give them meaning. Make sure you understand what they are. If you don't know that, hey, that means an elevated white count, look it up. Make sure you know it, because it is possible that you could see that medical terminology on your NCLEX exam. Amazing job. You all are impressive. So what are you thinking? What interventions might we consider? What things might we see in our nursing assessment? What are we thinking right off the bat here? LOC assessment, antibiotics, urinalysis. I love that. We need a UA on this client. Absolutely. We want to hydrate them. Definitely. You got it. All right. We're going to kind of move past this. So let's think about this. We talked about sepsis earlier, and I want to talk about what infections can lead to sepsis. Because in this client, they didn't just start out potentially septic, but there's lots of different things that could lead to it. So the different things that could lead to sepsis: pneumonia, UTIs. So is it possible that this client's UTI could turn into sepsis? What do we think? Could this UTI turn into sepsis? They might already have it, right? Yeah, absolutely. There's definitely a risk there. And really what sepsis is, I know I'm kind of skipping around in my slides, but I do want to talk about this. It's going to be where there's this mass infection that overwhelms the body's immune system and it leads to widespread inflammation. And so that's what we're going to see in this individual who has sepsis. Now, if you're like, Rachel, I don't got you. I don't know what sepsis is. I'm a bit confused. Or maybe you've got an NCLEX coming up. I want you to consider private tutoring. If you want to assess your readiness, if you want someone to work with you one-on-one, we have coaching. That's what I would call this. It is private tutoring, but it's really like coaching. It's someone who cheers you on, roots you on when things are tough, motivates you when you have a little bit of self-doubt, works with you to make sure that you are ready for your NCLEX exam and that you can walk into it with confidence. Private tutoring is more expensive than small group tutoring, but the reason why is there's so much value with private tutoring. The value you're going to get is that full hour is dedicated to you and exactly what you need. Private tutoring has been really busy the last couple months. So if you are interested, go ahead, look at the schedule now because there's a strong chance that the session you need will get booked. If it does get booked and you can't find anything that is available when you need it, reach out to us. You can reach out to us at nclextutors@archerreview.com. Let us know what you're needing for tutoring. We'll make it happen. So let us know, scan that QR code, or again, you can just go to archerreview.com and you can check out that private tutoring. So why do we think elderly are more susceptible to sepsis? What do we think? Why are elderly more susceptible? So both our clients, the first one had sepsis and the second one we're pretty sure is getting sepsis, right? Why is this? Good. Their immune system is weaker. They're not able to fight off those infections as well. Amazing job. Absolutely. Their immune response is going to be delayed. So that's why we don't always see the fever right away. Sometimes that fever comes later, and it's because the immune response is delayed. Nice job, everyone. Now let's go through that patho, because we already talked about what caused our client's sepsis, right? We're thinking the UTI probably is what led to the sepsis here. Now, typically what happens is there's some type of trigger. Some type of bacteria enters into the bloodstream, and that is going to lead to sepsis. And when this happens, our vessels dilate out. So if here's my vessel, it's going to dilate out. Well, if I don't change the amount of volume within that vessel, what's going to happen to my blood pressure when my vessel dilates? What do we think? Drop it in the chat. What happens when my vessel dilates out without changing the amount of volume in the vessel? It's going to go down, right? They're going to be hypotensive. It's going to drop. And so we see this hypotension and it's going to drop and it's going to happen quick. They might be okay. And then all of a sudden it's like, oh man, they're going down and they're going down fast. Well, when our blood pressure drops, now our ability to get blood to our organs decreases. And when we can't get blood to our organs, they don't get enough oxygen, right? Because hemoglobin, that blood, is what carries the oxygen molecules to all of the tissues in the body, all of the cells of the body. So that's not happening. And then we end up with shock. And what happens in shock is that our client goes into anaerobic metabolism. That's when lactic acid starts to produce, is when our clients are in anaerobic metabolism. That's when we're going to start seeing that lactate production. And the reason why is anaerobic is without oxygen. They're not going to have as good of metabolism. I'm trying to remember back to like cellular biology, but I want to say normally we make like 32 molecules of ATP, and in anaerobic metabolism, it's like 2 or maybe 4. I can't remember that far back, but it's a lot less. It is a lot less. So what important interventions are we going to consider? We've talked about this, but what are some things we might want to do? You guys should know this. We kind of talked about it in the first one. Someone did ask about feeling a little nervous about their test next week. I would love to touch on that at the end. Make sure you ask me that at the end. I can touch on that live. Anxiety is something I love talking about because it's so frequent in a lot of students. Good. Nice. Are we going to do the UA, blood cultures? Are we going to start those antibiotics? What are our lactate levels? Nice. So it's going to look the same, right? We're watching vital signs. We're watching, hey, what's that mental status? How's our urine output? And then we really want to make sure we're checking the urine. Do they have a UTI? And checking blood cultures. There is a chance, right, that they're not septic yet. There is a chance that they just have a really intense UTI. That's why we're checking all these things, though, because we want to initiate the sepsis bundle as soon as there is a risk, as soon as there's a concern that someone might be septic. So I'm curious, how would you guys describe a broad spectrum antibiotic? What does that mean to you? When I say a broad spectrum antibiotic, what does that actually mean? Okay, someone said gram negative and positive. It attacks the majority of bacteria. It's not going to attack it as well, but it does attack almost all of them. And so because of that, absolutely nice. It's the best one to start with while we're waiting for those cultures to come back so we can actually target the treatment. So I want us to go through and talk about what vital signs are we concerned with? What vital signs are we not concerned with? So let's just talk through these one at a time. Blood pressure. A blood pressure of 98/54. Are we concerned or not concerned? If we're concerned, I want you to put a C. If we're not concerned, put an N. What do we think? Concerned or not concerned? Okay. Look at the map. I want you to look at the map. That's telling you if we're concerned or not concerned. I'm actually going to put this under I'm not concerned. Now, a lot of you are like, what? That diastolic number, that's a little low, but my MAP is over 65. We're transfusing the vital organs. I'm okay right now. I'm watching it. Don't get me wrong, but it's not super concerning right at this moment. I'm okay with the perfusion because our MAP is above 65. Remember, a MAP of 65 tells me that we are transfusing our vital organs. They'll give you the MAP. When I've worked in the ICU, the MAP is right there. A lot of test questions, you're going to be able to see the MAP. Okay. So I know that you guys are like, what? That diastolic is low. Like, why is Rachel not jumping up and down? Because the MAP's okay. If the MAP was less than 65, then I would agree with you. We need to take intervention right now. Now, am I watching it? Am I taking blood pressures probably every 30 minutes? Probably. But right now, our organs are transfusing, and that's what's important. The heart rate is 123. Are we concerned about a heart rate at 123? We're concerned, right? When we're above 100, we've got tachycardia. Now, here's the thing. Am I surprised that they're tachycardic? I'm not surprised, but I do need to address it. 123 beats per minute. My client can't do that forever. Respiratory rate of 28. What do we think of this respiratory rate? Concerned or not concerned? Ooh, we're mixed here. We're mixed. I am a little concerned. That respiratory rate is high. Now, if I was only able to pick a couple things, it wouldn't be the thing I'm most concerned with because it's expected, but I am concerned. It's above the norm, right? Typically, when I see above 22 to 24, that's when I'm like, oof, I don't like that. And then our oxygen saturation, 95%. Concerned or not concerned? I'm not concerned. 95 to 100, we're golden. If it's at 89, then I'm a little more concerned, right? Now our temperature is 101.6 Fahrenheit, 101.6. Yeah, we're a little concerned about this temp. I'd love to get it a little lower, right? When temperature is high, it increases the oxygen demand that the body requires. So if we don't get it down, I wouldn't be surprised if that O2 sat starts to drop, right? And then the pain is a 4 on a scale of 0 to 10. And the client reports they're just not feeling right. Something feels off. What do we think? Something feels not right. When a client says that, does that worry us at all? When someone says something doesn't feel right, I usually get a little concerned. Now, pain 4 on a scale of 0 to 10, I know a 4 doesn't sound horrible, but pain is what the client tells us it is. If they don't feel right, if they have pain, we should work to treat that pain to whatever goal that they feel is appropriate. So if this client were to tell me my normal pain is a 0 and I'm now at a 4, then I'm concerned. So in this case, we don't know what their normal is. So I'm going to say concerning. We should address it. Now, in other scenarios, in real life, if the client tells me I live at a 4 all the time, I'm a 4 right now, but I'm okay, well, then I might not be as concerned. But in this scenario, I don't know what their normal is. So I'm going to say, yes, we need to address it. I'm concerned by it. The other thing is whenever I have a client tell me that something doesn't feel right, or they tell me I feel like I'm going to die, I believe them every single time. And the reason why, I've only had this happen a handful of times in my career as a nurse. Something bad has always happened the moment someone has said that to me. We are client advocates, which means if our client tells us there's a problem, there is a problem until we find out that there's not. Okay? We have to make sure that we're checking this client very closely because they can go from not feeling right, something's wrong, to now their vitals are tanking, to now their labs are tanking. Because in the elderly, their response, their systemic response is slower. We might not see the response until a little after they tell us something's not right, okay? So if you were to guess, what type of shock would you say our client is experiencing? If you were to guess the type of shock going on right now, what would you guess? There's different types. There's distributive shock. There's a whole bunch of different types. So sepsis is getting really specific. You're right. But what type of shock does sepsis fall under? What type of shock does sepsis fall under? Yeah, I kind of gave you all the answer because I totally said it without fully knowing I was going to ask you that. Yeah, I agree. Distributive shock. Don't mind my slide. It's cut off just a little bit here. But I know that this is distributive shock. Now, most of the time in distributive shock, in sepsis and in anaphylaxis, we're going to see that they're tachycardic. We're going to see they're warm and flushed. Now, one of the types of shock up here, we see bradycardia, not tachycardia. Does anyone know which type of distributive shock we actually see bradycardia in? Anyone know? Nice. In neurogenic shock, I can actually see bradycardia instead of that tachycardia. So that's a key takeaway I want you guys to get. Now, I want you to put any questions you have in the Q&A, whether you're joining on YouTube, Facebook, Zoom, drop it there, TikTok, drop your questions in. I'm going to do a little bit of time for Q&A, and then I'll go ahead and I'll show you our resources. So somebody said, hey, let's take a minute to talk about test anxiety. And for my coworkers joining me in the chat, they all know I'm going to get on my high horse on this topic, and we're going to be here a few minutes. So let's talk about test anxiety. Anyone feel comfortable? If you're in Zoom, raise your hand if you struggle with test anxiety, or if you're comfortable commenting, yeah, I struggle with test anxiety. Jennifer's actually going to go into this a little bit tomorrow in the webinar. So this will be a great little intro to it. But let me know who's struggling with this. Use that raise your hand feature in Zoom, or just let us know in a comment if you're comfortable. Don't share if you're not comfortable with it. So yeah, I've got, over 50 people that raised their hand on Zoom, and I've got tons and tons of comments that say, hey, I struggle with test anxiety. Hey, I've struggled with a test before. You know, test anxiety is really tricky because sometimes we don't even know we have it. And then we take an exam and it's the first time we've experienced. So what I want to give you the takeaway, since I only have a few minutes, is I want to teach you for a moment how you can control your test anxiety instead of it control you. If it's something you struggle with, guess what? It's never going to go away completely, but you can control it. I know this because guess what? I struggle with horrible test anxiety. I have forever. I'm in my master's program right now, and I still struggle with it. I had a advanced farm test that I took several weeks ago, and let me tell you, I was nervous as all get out for this test. It had a huge impact on my grade. If I didn't do well, it would have been a big deal. And I had to implement the measures that I teach you guys all the time. But if I wouldn't have implemented those, I know I would have scored a lot worse. So here's what you guys want to do. And I'm going to give you an analogy that I like to give, and then I'm going to tell you how to work through it. I want you to think of test anxiety, fear of failure, worry because maybe you're a repeat test taker, other people's opinions of you, the job offer that you've accepted, maybe the fear of not knowing what's next, the fear of, you know, self-evaluation when you start to analyze yourself during the exam. Think of that as I'm carrying a backpack, and each of those things is like a boulder. Okay, we're not a boulder, a small rock in this backpack. And I'm going to go hike up a mountain. I live close to the Black Hills. So let's say I'm going to go hike up one of the steepest hills around my area. Do you guys think I could successfully do it with that heavy load? Would I be able to make that hike up because of that heavy load? What do we think? Probably not, right? Like I'm going to likely fail if I tried to do it. So what I want us to do instead is I want us to lighten the load. I want us to stop caring what other people think. I want us to change our mindset because a lot of times we're our own worst enemy, to shifting from, hey, I'm talking poor to myself, to I'm going to fuel myself. I'm going to talk good about myself because I am worthy and I deserve to pass this exam because I've worked hard. So do that. Like, let go of the load, change the mindset. Don't worry about the job that you've accepted so much. Remember your why. Why did you go to nursing school? Why do you want to pass this test? Let that fuel you. Okay. Let that fuel you. Because if we keep worrying about what happens if I fail, guess what's going to happen? We're going to hold ourselves back from the full potential because we're so stuck in the worry instead of the question that is right in front of you during the NCLEX. So when you take the NCLEX, I want you to all walk in with the expectation that you're going to see 150 questions. And if it shuts off before then, awesome, that's great. But if it doesn't, that is okay. If it doesn't shut off before then, it is fine. But if it does, it's okay. But with the mindset of 150. And you're going to take it one question at a time, and you're going to go in and do your best. Because if you do your best is good enough. You can't do better than your best. Okay? So don't start to self-analyze. If you're like me, what I used to do is I'd be like, oh no, I don't know this question. I would write a tally on my whiteboard during the NCLEX of how many I thought I missed. That did not help me. I promise. All it did was fuel my anxiety. And then my anxiety level was up here. Now, one last quick thing about test anxiety, because I know I don't have long. We have to stop and address it when it happens. Our society kind of teaches, push through it, you'll be fine. Push through it, you'll be okay. That is not what I want you to do with test anxiety on the NCLEX. And if you have really significant test anxiety, please go see your primary care provider. But if it happens during the exam, I actually want you to stop yourself. Because if you just push through it and push through it and push through it, now your anxiety level's up here. And if you get up here, guess what? That's when your mind goes blank and you can no longer critically think. So instead, when it happens, I'm going to look like a goofball, but we know that I don't care. I do this all the time. You're going to close your eyes, and you can do breathing a few different ways. One way that Morgan, our chief nursing officer, does it is box breathing. Guess what? I can't count when I'm anxious. It's so embarrassing that I can't, but I'm not able to. So I just do 3 big deep breaths in through my nose, hold it, out through my mouth, in through my nose, hold it, out through my mouth. I do it 3 times. Do that right now. That puts pressure on your vagus nerve. And when you put pressure on your vagus nerve, it will actually remove you from your fight or flight. So now if your anxiety is here, you get it here. Your anxiety gets here, you get it here. Your anxiety is here, you get it here. So your highest anxiety might be here, but before when we just pushed through it, it was up here. See that difference? So that's why we're constantly addressing it. Take a break at question 86. Take another break at question 115 to 120. Those are times naturally that I've seen thousands of students start to get test anxiety from doing this job for almost 4 years of education, almost 3 with Archer, right? Make sure you take some breaks. Question 86 is a big one because if you don't pass in the minimum, there's just this automatic of like, am I doing okay? You don't give up at all. You go full force with your full effort through question 150. Okay? Through question 150. Now, lastly, mindset is the biggest piece of this, and that starts today. Remind yourself that you are smart, that you are capable, that you are able to do this. Tell yourself that you've got this. And how you know that you are ready for this test, for Archer Review, that's the company I've been with for almost 3 years, is you've passed 4 readiness assessments with highs or very highs consecutively. So you're going to go on over to Archer Review Nursing, NCLEX RN or PN, whichever one is you, and you're going to get the Sure Pass package. Get 4 highs or very highs. Attend the 3-day live review. Give it your all, because this is my mindset. If you're going to do it right. Give it your full effort so that no matter what, when you walk out of that exam, you have 0 regrets because you know you did your absolute best. And then we go from there. But if you do your best, there is no regrets that you can have because you did your best. And that's all anyone can expect of you. That's all I expect of you, is to do your best, to show up each day and try to be 1% better than you were yesterday. All right. I think that is pretty much time to wrap up. If you're interested in the tutoring, I said I would show you how to get that. You'd go to private tutors, NCLEX. There's also nursing school tutoring. Rachel Devon, who's in the chat, does nursing school tutoring for assignments, for paper writing. She can help guide you through the process. But NCLEX tutors you're going to find here. Diane sold out for the day, but Emma has private tutoring available. If you're struggling with test anxiety and you've got a session coming up, she is your girl. She is awesome. Super duper helpful. And then on Thursday, we have tons of sessions. Shelly's got test taking strategies. That's priority. These are 2 I recommend every student take before their NCLEX. Kate has a 2-hour NCLEX review. So does Lauren. If you need a day session in the morning versus a night session. These are sessions I highly encourage. The 4 I always say are the 2-hour NCLEX review, test taking strategies, and priority. Those are my top 4 sessions that I recommend. If you book, let me see here. If you book 3 or more, you get 10% off. At 5 or more, 15% off. So if you're like, oh, I've only got a couple weeks, those are the ones I would prioritize. The others are nice. Don't get me wrong. They're good. Those are my top 4 for someone to take before they go take their NCLEX exams. Hopefully today was helpful for you guys. I hope you learned something. Jennifer will actually be live tomorrow. Let me look at the time. On Facebook, YouTube, and Zoom, not on TikTok. So if you're on TikTok, go ahead, follow those other platforms. But she will be live on Zoom, Facebook, YouTube tomorrow at 5:30 Central Time. And she's going to talk all about how to conquer NCLEX nerves, because I know you guys have got them. Now, someone said, if we buy SurePass, are all the lectures free? Everything is included with SurePass except for our farm crash course. You get Monday through Friday, free live lectures. Tuesday, Thursdays are 3-hour content lectures. Monday, Wednesday, Friday are 1-hour case studies, like what we did today, but way better than what I did today. There's 32 different case studies that you'll go through, and those are all included in the SurePass package, as well as our 3-day live review, which is a 24-hour high-yield NCLEX review. It comes with literally so much when you get the SurePass package, because we wanted to provide an exceptional value. We wanted to give everyone the opportunity to pass, and we wanted it affordable. So that way anyone would have the opportunity to get their hands on what we had to offer for NCLEX prep. Thank you guys so much for being here. If you have any questions, you can always email us, nclextutors@archerreview.com. We appreciate each and every one of you. Thank you for being a part of the Archer Review community. Good luck to each of you. I can't wait for you to join us in the nursing profession. Bye, everybody. I hope you have a great